In addition to my introduction, we do work on policies change, but we work and organize with people who've been harmed by medical care, their families, advocates that work for and with patients. And these are really the people who are the center of the power of this patient safety movement that I think don't get the kind of recognition that they should normally get. As people like Emily, who spoke earlier, they really are the power behind all of this. And they are not and should not and wait for someone else to fix it. I mean, we want the system to be accountable, but we can't wait for it to be fixed. And I want to acknowledge, I'm very grateful to be asked to return to Health Watch USA. I came here a number of years ago, but it's been a while, and it's always a great conference. I've been working, as you heard, on hospital infection rates being published for nearly 15 years. And I've been thinking in preparation of this about what's the next phase, where do we go next, where, we definitely haven't fixed the problem. And so today I want to just talk real briefly and focus on three things. The value of public reporting, has the value that it's brought to patient safety, public accountability, and the need for more reporting, types of reporting. So I'm a firm believer, unabashed supporter of public reporting. I think it's the foundation. It's not the end all to be all, but you have to have it to know if you're making progress. And you've heard a lot about disclosure and public reporting. And while I'm going to mainly focus on hospital infection reporting, all of this applies to any other kind of public reporting. It can apply to information you get from medical boards, information you get about other healthcare providers like nursing homes and outpatient surgical centers, things like that. So I'm not going to read this, but you can see that our feeling is that these work if they're being used, this data, and that use can be internal within the hospital, external. We think it needs to be used in enforcement and by researchers who are catering to a certain population. And of course, we think that patients and consumers should be able to use it. And even though it's kind of hard to understand sometimes, maybe they don't have choices, they can use it to raise questions and get information from their providers. And it works if it's complete. And by completeness, it means you have to have multiple people reporting. We just heard about the MOD system, and the volumes of reports from that system are pretty large, but they have many reporters. Right now with infections, we basically have the reporters are the hospitals. And, we know it doesn't take rocket science to figure out that people don't like to report when they screw up or when something happens that is not intended or not wanted, of course, and if it causes harm. So there is some issue with them being the only reporters. It also has to be timely in order to be relevant. And most of what we see, as you all probably know with healthcare, is that it's quite old. And the multiple sources might be multiple reporters, but it also might be sources, as we heard earlier, like death certificates, which has been a major issue since I first started on this project. I think the first person I talked to talked about death certificates. The death certificate did not reflect what really happened to my mother. Currently, we do have reporting. It's limited. It probably reflects only about 25% of all infections that we think are happening, if that many. CDC collects a lot more information than that, but they don't reveal it. And as I said before, it's often dated. When you look at things like the superbug infections, we're only getting lab-identified MRSA and C. difficile. infections, which is a very small subset of what's actually happening out there. And also we don't see much in the way of devices and common surgeries. Infections related to common surgeries is pretty limited. A few states require reporting that, but not nationally. So at Consumer Reports, we've been surveying people for many years, and these are just some of the things that we found. Of course, it's not surprising. Most people want to have more information about errors, and 29% of people told us in 2015 that they'd experienced at least one of 16 listed errors that we provided to them. And these are national polls. They are randomly selected, so it's a pretty good national basis on what people really want to know. So information varies from state to state. I took a Kentucky example, which some of you might know. The only thing available for this hospital is on Hospital Compare, which is a federal site. It's pretty limited, but I looked at their ratings for complications and deaths, and they have a star system. They have 4 stars, which to me, 4 stars is exemplary, right? You know, it's not average. It's 4 out of 5 stars, so it's above average. But during this period where they got 4 stars, they had 204 infections, which might not sound like a lot to somebody who works in a big hospital, but it certainly would sound a lot to the people in your community. To have that many in a year, that's nearly 4 a week. And we know that this is only a subset. But overall, when you look at each measure separately, all but 2 of the measures came out. You know, they kind of do a comparison sort of status on these reports, and they're either better than, worse than, or no different than others. So this hospital was mostly no different than others, but had 4 stars, and in 2 categories they had one that was better and one that was worse. So this is the kind of information that we have available to us now. Looking at the University of Kentucky in Lexington, we've got 3 stars. They had more infections, about 6 a week. And I think that people see that as a problem. Again, it was no different than others, except in 2 categories where it was one better and one worse. And so when you have these sort of cookbook reports, they serve a certain purpose, but it's important to have other analysts come in and look at it in another way. So generally, we're missing a whole lot of this picture, including a whole lot of infections acquired in the hospital and infections in other settings, and real-time information like outbreaks, which we heard a little bit about earlier. And we think that there are ways that patients and other kinds of providers, like nurses, could fill in some of this data. So let's talk a little bit about outbreaks. We did some polling at Consumer Reports and found that most people thought that patients who are directly affected should be totally notified about this outbreak, which doesn't happen a lot. They think the doctors who are treating the patients should be advised about the outbreaks, and more than 50% think that patients in the hospitals and those being admitted should be advised that an outbreak is going on. Yet, as we've heard before, most of this is kept secret, and we've got many stories of people, as was told earlier, walking into a hospital, checking in, getting some procedure and getting an infection where an outbreak is going on at the same time, and they were never notified. And the other thing is that I'm just going to do an aside as a policy person, so I don't forget at the end, but Deb's presentation reminded me that while I'm kind of focused on requiring states to mandate that these outbreaks be public and people be told maybe where we need to start is to get rid of the states that bar the reports from being made. So that's the first hurdle. If you have a prohibition, a total confidentiality of this information, then that is, sort of a first hurdle. And then I remember the first time I found out that CDC doesn't know about these either, and they're only brought in if the hospital asks them for help. So they're kind of hands off, and I think most of the public thinks that they would get in there and really help take care of things, and that just doesn't happen. So another example of an outbreak from a woman who had C. difficile infection, and she was very sick. But once she was able to get up and walk around again, she noticed that all the other rooms had C. difficile caution signs, and she had no idea that she was part of a bigger outbreak. Many people, when we talk about requiring reporting of outbreaks, give the same response that we got when we talked about reporting infections. They said, well, there's no definition of an infection. And I said, well, that's why you need a law to define it. And that's what should be reported. Same thing for outbreaks. We would need to define it if it was in the law. Real quick, another example of an outbreak that we were involved in California. It involved a MERS outbreak in an NICU unit. Went on for 8 months, 10 infections that we know of. The county didn't expose it. They said there wasn't any evidence of a higher risk than elsewhere. The hospital didn't notify incoming patients to labor because they said they isolated the babies and notified those parents of those babies. Once that first LA Times article came out about this outbreak, one of the mothers came forward and said, well, my baby got MRSA and nobody told me that was part of an outbreak and my baby was not isolated. So a lot of times I think hospitals respond and they're not completely forthcoming with all of the facts. And we believe that they have a right to know, even if you don't know the source of the infection. It's really unethical to withhold that from the patients who should have a choice on whether they come in or not. So this was a great comment that somebody put on the LA Times site and about it being disturbing because it looks like they tried to hide the MRSA outbreak, and that covering it up is probably worse than reporting it because it causes distrust of the hospital. And I really agree with that. I think honesty is your best policy. Coming forward and saying, this happened here and here's what we've done to fix it is a real important step for hospitals to take. So let's talk about accountability and safety. They are tied together, these two issues, as we've heard, and we do need more than just public disclosure. We need an oversight system that works for us, that protects the public. Almost every oversight system, whether it be over doctors or hospitals or nurses or home health agencies, they all have a mission to protect the public. And often that doesn't happen. There's often a really close relationship between these overseers and the people they are overseeing. And so it's difficult to confront them. And we've heard lots of examples about the need for accountability, and I'm not going to repeat it because all the other speakers that came before me really made a compelling case for that. So in California, I'm actually based in Texas, but we did a lot of work in California because we had some funding for that work. We discovered, some activists discovered, that there was this thing called a firewall, and we call it a cultural firewall among public health systems, that the infection control people don't talk to the enforcers about the infection rates. And the problem with that is that the public health side doesn't have enforcement powers, and the investigation side does typically. And in CDC's contracts with state health departments, they say, we'll give you the infection data as long as you don't share it with the investigation or enforcement side of your agency. So earlier this year, we petitioned the California Health Department to call on them to share information with their enforcement division right down the hall, and for that enforcement division to use it as a prioritize their schedule for inspections, regular inspections, and when they go in for investigations, for example, of complaints, that they look at the history of this hospital, because as you know, those investigations, if they find a problem, they come up with an action plan to correct it. And often the action plan is really just targeted at one thing. Oh, they had a problem with a sink, they had a problem with, where they kept equipment or whatever. But if it's a systemic problem, if you've got this hospital that's had repeated high infection rates, then you might have a different kind of correction plan for that would be more effective. Now the California Department of Public Health is sharing this information, and we think that not all states, but many states have this cultural firewall. And certainly CDC condones it, and I've personally had many conversations with them about removing that condition on their contract. Kentucky has that because you don't have a state reporting law that is separate from the CMS requirements. So one of the things we did in California is we focused on the hospitals with high infection rates, and nearly 60% of California hospitals, we looked at the last 3 years, and nearly 60% of them had significantly higher infection rates than other hospitals. These are truly the outliers. If you know anything about the way these are reported, the band in the middle of no different than is pretty broad. So if you're an outlier, you're better or worse, those are pretty good indicators that you are better or worse in those categories. And what we do find is that some hospitals have infection rates that are better in preventing MRSA, for example, and not so good at preventing C. difficile infections. So we do see that variation within hospitals, which continues to be a problem and indicates there's not a sort of a system-wide infection control that's being effective. So we looked at 3 years, and we found that quite a few of them had at least one higher rate. Most of them had one or two types of infections that had high rates. 38% had high rates over multiple years or multiple types of infections. One had high rates 12 times in numerous categories. Now, I want to say one thing about California. They report on 29 different kinds of SSI, surgical site infections. They report on a number of other types of infection that most states don't have. So they have a great deal of information for that state. So when you have that kind of detail, one of the things we did, remember that hospital, it was University of California at Irvine, that had the NICU outbreak. And so I decided to drill down and see what other problems they might have had. And 6 times in the last 3 years, they had high infection rates, higher than the average hospital. Their C. difficile infections were higher every year and involved 406 patients over 3 years. Most of their central line associated bloodstream infections were lower or no different in all categories of units, because they report they're based on ICU types and also wards. Hospital wards, but there was one unit, this temporary lines in a hematology oncology unit, that had a very high SIR, which is the score that CDC uses to sort of compare hospitals with each other. The number 1 is the baseline from a number of years ago. So you want to see the SIR to be going in the other direction. Less than 1 SIR means the hospital's moving in the right direction. More than 1 means they're not. And this SIR is quite high and probably indicates an outbreak happened at that unit, would be my guess. Then when we looked at the surgical site infections, we saw that twice, 2 years in a row, they had high rates in rectal surgery. Now, there's no place in California where a consumer can go and find that other than to drill down like I just did. And so we think it's really important for someone to do that for consumers, with consumers, and we're working on trying to do that on a more routine basis through consumer reports, but also using our network of activists to try to get the word out on a local level. It's really important to get it out locally, I think. Oh, and the other thing that I think it's really important, when you look at these infections, these are hospital onset cases. Now, those of you who are nurses probably know that most of the infections show up after you leave the hospital because they get you out of the hospital pretty fast, which typically is a good thing. So we don't know much about a lot of the community onset. So this is really a small subset of what's actually happening. So I'm just going to speak very briefly about antibiotic resistance, that it's urgent. I had the surprise last week of reading an email from one of my colleagues who pulled up a 1995 article in Consumer Reports that gave tips and called on doctors and drug makers and patients in the same way we're calling on them now to quit overusing antibiotics. This is really urgent. I'm not going to dwell on it, but it's a real priority for our country, and I think we have a real problem here, and we all need to be working to solve this problem, to quit the overuse of antibiotics and inappropriate use. Okay, so real quickly, we have federal websites to report all kinds of problems. Drugs and devices you heard about from Idris, food-related illnesses, vaccination problems, credit cards and banks and cars. So this data is out there. People can report when they have a problem. Manufacturers can report. Anyone can report these problems. But here we have a problem that affects the lives of millions and millions of people every year, and there is no place for us to report infections. There are also some private ways to report things, like the bed bug registry, which all of us like to consult when we travel a lot. And while this is certainly more complex than bed bugs, this is an example of how we might be able to get information out to the public. So we think we need a national system for patients and families to report healthcare-acquired infections that's transparent to the public, similar to the FDA database. Now, if we got that, someone's going to have to take that data and do something to analyze it and make it usable. We cannot wait for the federal government to do it exactly like we want. And I would want the information to be shown in a different way than perhaps a nurse or a doctor's group would want the information. So it's real important to have the raw data available that can be used. So there are many values of a patient reporting system. Again, motivating better treatments. Patients need protection, and we need more sources of information. And right now, hardly anyone knows about outbreaks unless it happens to get out into the newspaper or something like that. And researchers, I think, and epidemiologists are missing a lot of data. And there's plenty of evidence out there that patients do report accurately, in fact, more accurately than hospitals. So how can we improve this? That was the question asked, and I think more drilled down analysis, especially on a local level. When Consumer Reports comes out with our national report, it's, an article, maybe some other newspapers repeat it, but very rarely does it get locally where people care about their own hospital. And so we need to do a better job at getting this information out. We need more focus on appropriate antibiotic use because there's really no information about which physicians are overusing, which hospitals are inappropriately using, and I think that that we're at a point where it's so urgent that we need to start identifying these people, if for no other reason, to target them for help. What are the strategies that can be done or used to prevent this overuse? And a lot of times it might be just ignorance of or lack of resources to figure out what exactly is the right antibiotic to be used at a certain time. Some people in our group are working really hard to push for rapid diagnostic tests so you can tell if an infection is viral or bacterial. And I think that once that gets in the hands of doctors and maybe even patients, that would make a difference. And we need to change the culture of the health departments and as one of collaborating with enforcement when it's needed. There's a certain point where I think we're past that point. We've been spending the last 10 years really focusing on using this data to try to help hospitals improve. And now we need more emphasis on, mandated corrective action plans that actually make a difference. And I think that this will help frontline workers, or it should, because if the people who control the purse strings at the hospitals don't have somebody coming down on them, they probably are not going to come up with the resources needed to fix it. We need patient reports, of course, and I'll just say full disclosure to patients when infections occur, let them know what happened is a real important part of patient-centered care. And often when we talk, there's a lot of talk about patient-centered care, but it rarely focuses on how do you create a patient-centered environment when harm occurs. And we would like to see more discussions about that. So thank you very much for inviting me. And if anyone has any comments or questions, I'd really like to hear your ideas about what needs to happen policy-wise or otherwise to improve this problem.